Okay, welcome back. I'm excited to introduce our next speaker, Dr. Uribarri from New York, and he has been in Icahn School of Medicine, Mount Sinai, New York City since 1990, and he currently is Professor of Medicine and Director of the Renal Clinic and Home Dialysis Program at the Mount Sinai Hospital. In addition to his clinical activities, Dr. Uribarri also been very active in clinical investigation for the past 30 years. Main interest of research has been acid-base and fluid and electrolyte disturbance, as well as nutrition in chronic kidney disease. And welcome, Dr. Uribarri.
Thank you very much for the invitation to speak to your meeting today. And no disclosure to present. And that went a little bit too fast. And the purpose here is to discuss the potential role of AGEs, more specifically dietary AGEs, on the kidney disease in general. Let's start by defining what are AGEs, advanced glycation end products. They are a heterogeneous group of compounds resulting from the spontaneous, non-enzymatic reaction of the carbonyl groups of sugar with free amino groups in proteins. Now, again, showing here the free amino group, we're reducing sugar, and I'm having a problem now with the presentation, I'm sorry. And again, it's a non-enzymatic reaction that leads to a series of intermediate reactions, finally to the formation of irreversible advanced glycation end product that we call AGEs. Again, to visualize the same thing, in the brown area, you can see the classical so-called Maillard reaction or Browning reaction of the reducing sugar reacting with the free amino groups, forming shift-based amyloid products, still reversible compounds, and then going down to the formation of the irreversible compound, the AGEs. Examples there, CML or carboxymethyl lysine pentosidine. What is important here to get is that there are many other pathways by which AGEs form besides the classical Maillard reaction. And even more important from a clinical perspective is that AGEs can actually form without the presence of glucose. So you do not need hyperglycemia to form AGEs. And in fact, I will demonstrate you in a few minutes that patients with chronic kidney disease, even those who do not have diabetes and hyperglycemia, will tend to have very high levels of AGEs. Now, in medicine, we care about these products because these compounds lead to inflammation and oxidative stress, processes that eventually lead to chronic diseases such as diabetes, cardiovascular disease, and chronic diseases. In general terms, the toxic effect of AGEs are through two general mechanisms. Number one, AGEs may directly cross-link proteins and therefore altering their extraction and their function. As an example, glycation of collagen fibers in the skin and vessel wall changes the characteristic of this protein and their holding tissues, and this may lead to the production of wrinkling under the skin and stiffness in the arterial wall. On the other hand, AGEs acting through non-receptor and receptors on the cell surface may activate a good number of cell pathways that eventually lead to increased production of reactive oxygen species and inflammatory cytokines. So these are the general two mechanisms: direct cross-linking and activation of a receptor, mostly the RAGE receptor, leading to inflammation and oxidative stress. Again, there are several kinds of AGE receptor. The most well-known, some of them are pro-inflammatory like RAGE, and some anti-inflammatory like AGE-R1. If you look at the surface of many cells, most cells, they will have then some receptor like RAGE, TLR4, that can bind to AGEs. And when they bind to AGE, that leads, as I mentioned before, to activation of inflammation and oxidative stress. When AGEs bind to AGE-R1, That activation somehow tend to decrease the activation of inflammation on the one hand, and on the other hand, this receptor itself increases the endocytosis and degradation of AGEs. Therefore, the more AGER1 you have, the more you break down AGEs. Now, AGEs are very well known as compounds generated endogenously in diabetic patients as a result of hyperglycemia. However, fewer people are aware that AGEs are naturally present in all foods, and that this amount is greatly increased by processing and or cooking foods under high heat. Heating of foods generate AGEs, and the AGE content increases as a function of the type of food, duration of cooking, level of heat, presence of moisture, pH, cooking surface, and so on and so forth. In fact, this is well understood by food scientists. They have learned how to manipulate cooking techniques to get the exact color, aroma, and taste of the food they desire. We and others have demonstrated that a portion of the AGEs in foods gets absorbed and incorporated into the body AGE pool, becoming indistinguishable from the endogenous AGEs. So if you take an extract of food with AGE, food-derived AGEs, and apply it to any cell system in vitro, you are going to have that, again, the same function described, the same effect that I mentioned earlier for AGEs in general will be here, cross-linking and protein and activation of receptor leading to degeneration and pro-oxidative and pro-inflammatory state. If you look at animal models, more specifically mice, a high AGE diet in mice have been shown to lead to diabetes type 1 and type 2, vascular disease, kidney disease, insulin resistant, impaired diabetic wound healing, short lifespan, dementia, you name it. Whatever disease exists in the world, you can give it you can reproduce it in the mice by simply giving them a high AGE diet. And more importantly, a low AGE diet has prevented all of the same above conditions. Now, dietary AGEs and the kidneys may have a dual role in the sense that may contribute AGEs to the progression of kidney disease, cardiovascular disease, and diabetes. And in end-stage renal disease itself, dietary AGEs may behave as uremic toxin in the sense that can induce inflammation and oxidative stress, can favor insulin-resistant generation and cardiovascular disease. The effect of dietary AGE in the kidneys has been studied in a large number of work, both in vitro, animal studies, and human studies, and I don't have time to go into each one of them in detail. But again, the fact that a low AGE diet prevents disease in mice does not assure it will do the same in humans. As a physician, my main interest has been to define if dietary AGEs are relevant in humans. For about 2 decades now, we have been addressing this issue in several studies, looking at association between dietary AGE intake, serum levels of AGEs, and other circulating biomarkers of disease, looking at the effects of acute oral AGE loads on vascular function, and so on and so forth. But at this time, given the constraints of time, I will just present to you some results in terms of the interventional studies, clinical trials with a low AGE diet, because I believe that they are the most important in this case. Before I go to the studies that we have done in this sense with a low AGE diet intervention, let me give you some background information to explain how these studies were performed. Okay, let me bring you back to the basic concept then that we are saying. We're saying that common Western diets are very rich in AGEs, that the application of food, cooking food with heat under dry conditions such as grilling leads to significant formation of AGEs, especially in animal-derived foods, also rich in AGEs. And these images depict the AGE-rich foods we are talking about. Now, we have generated an AGE, dietary AGE database with a large number of food items. We have taken different kind of foods, we have cooked them under different conditions, and we have measured AGEs, in our case, by a specific antibody ELISA technique measuring carboxymethyl lysine CML. But other dietary AGE databases already exist in the literature published by some other groups based not only on antibodies, ELISAs, but on mass spectrometry and so on and so forth. Let me give you an idea of what I'm talking about. You can take the same piece of food, for example, chicken, and you boil it with plenty of water for, let's say, half an hour, and you generate a certain amount of arbitrary unit of AGs, in this case, 1,000. You take the same size amount of chicken, and now you broil it for the same length of time, you generate much more AGs. Repeating, if you take beef stew with plenty of water, you generate a certain amount of AGs. If now you fry the beef for the same amount of time, you generate many more. And you can continue like that over and over through the different products. So in other words, the basic idea here is that it is not just the food, I mean, if it is meat, if it is a plant or a fruit, but it is the way the food has been cooked. And just modifying the cooking technique, just modifying the culinary technique, we are able to modify the AGE content of the diet. So when we're doing all these studies that I'm going to mention to you, essentially what we do is that we take people, we talk to people, and we get a dietary history. And not the usual dietary history, essentially the same, but we add the question, how was the food cooked? That is the important thing. And by doing that and relating to our own dietary database, we can determine how many AGEs that person is eating at baseline. Then we modify that amount by advising them how to cook the food in a different way without necessarily changing the food that they're eating. In other words, we try to keep the same amount of calories, protein, carbohydrate, and fat as much as possible during the whole process and only change the content of AGEs. And that is done predominantly by changing then the way we cook. Again, another concept of taking the same amount of meat and cooking under different conditions, generating the same different amounts of AGEs. So this is the basic concept of a low AGE diet, to teach people how to cook in a way that generate less AGEs. In a seminal study already published in 2002, we took a group of diabetic patients in a crossover design and randomized them to go into either a regular or high AGE diet and a low AGE diet based in the concept that I mentioned before. And because this was a crossover design, each patient went into a high and a low AGE diet at different times, and there was in between a washout period. In this case, patients received all meals prepared in the Mount Sinai School of Medicine Clinical Research Center, and the patient collected them twice a week. Now, let me tell you what happened at the end of this. This is a complicated slide, but let's go piece by piece. Let's concentrate in the upper panel. To start with, all the units are compared as a percent of change from baseline because each parameter has different units of measurement. Okay? First, if we concentrate in the upper panel, you can see that a low AGE diet was associated with decreasing blood levels of at least 3 markers of AGEs, are shown here, while a high AGE diet produced exactly the opposite. Please pay attention to the fact that levels of blood AGE decreased by as much as 40%, despite same degree of diabetic controls in this patient. Up until the moment of publication of this manuscript, serum AGE levels in diabetic patients were thought to result exclusively from hyperglycemia, and therefore showing a striking fall in levels of AGEs while maintaining blood glucose control about the same was unexpected and a very novel finding. If you now pay attention to the lower panel, you will realize that a low HG diet not only decreases circulating HG levels, but also decreases circulating levels of markers of inflammations such as CRP, TNF-alpha, and endothelial dysfunctions such as VCAM1. The fact that a high HG diet does exactly the opposite strengthens even more the finding. So these findings in 2002 allow us to delineate a new paradigm that we have called the HG story or HG hypothesis, in which circulating HG, serum HGs in this case, originate not only endogenously from hyperglycemia or any condition of high oxidative stress, but also exogenously from food and tobacco even. Whatever the source of HG, they lead to an increase in the pool of HGs in the body, which eventually increases oxidative stress and produces microinflammation that eventually over time induces chronic diseases. This is our postulation. This is what we have been working for a while. Now, to further strengthen our postulation, we took then another group of patients, another group of diabetic patients, and asked them to follow the low HG diet for the next 3 months. So these are patients which in the natural state were on a high HG diet or regular HG diet, as it is written here, and based that on getting a dietary history, and then randomized to either follow the same or go in a low HG diet for the next 3 months. The patients were preparing their own meals at home, but under the constant either phone or face-to-face supervision of research dietitian. This was a proof of concept thing, so research dietitian play a very intense role to demonstrate that it was possible to do it. As you can see in this slide, I'm showing you only what happened with a low HG diet, and again, as a percent of change from baseline. The low HG diet in this patient brought down the levels of carboxymethyl-lysine, levels of markers of inflammation such as TNF-alpha and RAGE, a marker of oxidative stress such as 8-isoprostane, and very, very interesting, HOMA index, which is considered by many as a marker of insulin resistance. This is a very important finding. We took patients with diabetes, and by placing them in a low HG diet, we decreased the level of insulin resistance. Moreover, we increased to almost normalize levels of two factors that were very suppressed at baseline, AGR1, that, as I told you, has a protective role, and SIRT1, sirtuin, which also has an anti-inflammatory role. Then we went to a third group of patients with at least 3 components of the metabolic syndrome, and we follow the same pattern of a study. We chose those who on the natural state, on the usual, regular, habitual state, consume a high HG diet, and randomize them to go into the same diet or go into the low HG diet. Again, patients prepare their meals at home under the constant supervision by a research dietitian, telephone calls at least twice a week, face-to-face very often. This study looks 12 months, and I can tell you that from dietary supervision was a very, very intense study. We had meetings twice a week going through each one of these patients and what could we do to reverse whatever changes from the dietary assignment took place. Then this is reflected in results in terms of what happened with the low HG diet. And the findings almost reproduce what we found with diabetic patients. HG's levels go down, markers of inflammation such as TNF-alpha and RAGE go down, markers of oxidative stress, isoprostane go down, HOMA-IR goes down, we reverse the insulin resistance that you find already in patients with metabolic syndrome. AGR1 and SIRT1 that were suppressed at baseline went up, And glyoxylase, a most important enzyme regulating the levels of methyl glyoxal, a precursor of AGEs, also that will suppress on baseline, increase, and this will allow to break down even more AGEs. So this finding that we have had on diabetic patients and in patients with a metabolic syndrome has supported in us the idea that the relationship between AGEs and diabetes is not only the classical one, very well accepted, that hyperglycemia can lead to high levels of AGEs, but we are saying indeed that high dietary AGEs itself produces insulin resistance and therefore induces diabetes, almost the same as in mice. Now, I'm spending time about this in this session of kidney diseases because diabetes is the main cause of renal disease in this country. In fact, about 60% of ESRD patients in this country are so because of diabetes. Therefore, if we prevent and or improve diabetes, we will have a large impact in renal disease. Now, what about dietary AGEs and the kidneys? We have done the following study. Number one, we took a group of patients on peritoneal dialysis on a high habitual intake of AGEs, and then we randomized them to either continue the same diet or go in the low AGE diet. For the next 4 weeks, patients prepare their meals at home under the constant supervision of the research dietitian. And at the end of that period, you can see that again, the same effect happened. The levels of an AGE, carboxymethyl lysine, came down. A level of marker of inflammation, CRP, C-reactive protein, came down. Then we took a group of chronic kidney disease patients not on dialysis with an average serum GFR of about 30 ml per minute and non-diabetics to differentiate clearly that we could do the same in CKD and relate it to the diabetic condition. Again, these patients were on the habitual state ingesting large amount of AGEs, and we randomized them to the same diet or low AGE diet for the next 3 months. And again, patients prepare their own meals at home under the supervision of the dietitian. And the findings were remarkably similar to what we found in diabetic patients. Low AGE diet, reduce AGEs, reduce inflammation, reduce oxidative stress, and increased levels of R1. We then learned that a compound that we use frequently in nephrology, sevelamer, to control serum phosphorus, in vitro, we learned that it could bind to AGEs. So we wonder if we could use this in vivo, and did a small pilot study in which we compare sevelamer versus another phosphorus binder like calcium carbonate. Okay, this was a crossover study where we compared then sevelamer carbonate 1600 milligram PID together with meals versus calcium carbonate 1200 milligram 3 times a day together with meals, and it was a crossover design with a washout period of 1 week in between. In this case, patients were advised not to change what they were eating. We tried to keep the dietary intake of AGEs as constant as possible. And what we found again, if we look in the changes from baseline, is that the low AGE diet brought down the levels of AGEs, markers of inflammation and oxidative stress, and the increased SIR1 and AGER1. I actually said the low AGE diet, though in this case there was no low AGE diet. The AGE diet was constant, but the addition of sevelamer introduced that, determining that sevelamer then behaved like a low AGE diet. So we assume that administration of sevelamer together with the food bound AGEs and acted like a low AGE diet. And as you can see, calcium carbonate, which also was binding phosphorus, as we demonstrated with reduction in the 24-hour urine collection of phosphorus, did not have an effect on AGEs. This table shows that these kind of studies have been reproduced by many other people, not only in people with diabetes, but also in patients with chronic kidney disease and even in normal individuals. All these findings, again, reinforce what I told you at the beginning, what we tell as the AGE story. Endogenous and exogenous AGEs contribute to the body AGE pool that leads to oxidative stress, inflammation, and eventually chronic kidney diseases. Now, in the past few years, there has been some information suggestive that, in fact, AGEs, exogenous, may not only come preformed from the food that we ingest, but that they may form intraluminal within the intestine, particularly with the intake of high fructose corn syrup, fructose. And I don't have time to address this particular issue, but nowadays then most people will agree that the sources of AGEs into the body are either endogenous or exogenous. And exogenous will include eating AGE-rich foods, perhaps the intraluminal generated AGEs, and smoking tobacco. What happened with what is the fate of these exogenous AGEs, either coming from the diet or AGEs from intraluminal? A small percent will be absorbed and incorporated into the body AGE pool, contributing to an oxidative stress inflammatory state. The remainder will be delivered to the colon, where it could be excreted in the stool, interact with race receptor in the wall, initiate a localized inflammatory process that could become systemic, or interact with the microbiota in a variety of ways. In fact, there are many examples that AGEs and the colon bacteria interact. For example, just to give you a few, some lactobacilli make glyoxylase, the enzyme that breaks down methyl glyoxal, and potentially, therefore, eliminates AGEs from the diet. E. coli may actually secrete AGEs and contribute to inflammation. Carboxymethyl lysine, CML, has been shown clearly in vitro to be degraded by E. coli. So our current interpretation of the metabolism of dietary AGEs is represented in this cartoon. Exogenous AGEs ingested via cooked food or formed in situ in the intestine, a small percentage will be absorbed into the circulation. The majority of them excreted by the kidneys. A small percentage will remain, inducing protein cross-linking, having cellular effects of inflammation and oxidative stress that over time will produce problems. Those which are not absorbed, they go into the colon and they may be eliminated in the stool, but also they may have some other effects. For example, they actually can stimulate the race in the wall of the colon, producing local inflammation that by itself can eventually lead to systemic inflammation. And as I said before, can modify, affecting the microbiota, local fermentation, production of new compounds, including new AGEs, and increasing the colonic wall permeability. By now, it has been shown in animals, and at least in 3 significant studies in humans, that a high dietary AGE clearly modifies the intestinal flora. Exactly what is the meaning of this modification is not so clear, but the point that I'm trying to make is that when you have a high dietary AGE intake, the end result is not only resulting from those fractions absorbed in the upper GI tract, but in fact, some of the unabsorbed AGEs that are delivered into the colon may contribute to systemic inflammation indirectly by local inflammation, producing inflammatory bowel disease, generating food allergies that produces, again, systemic inflammation. Again, tobacco or air contamination also contains AGEs that may be incorporated through the bronchial trees, producing bronchial inflammation and asthma. There are very good studies showing this, which in turn may later produce systemic inflammation and oxidative stress. I'm giving you a very positive analysis of the result of the studies that we have done in terms of low HGE intervention. To be candid, not everybody accepts this interpretation. And there have been many arguments against this interpretation of the effect of dietary gene modification. For example, one argument is that lower energy diet content may also decrease caloric intake. True, but in our study, we have it has been painful detail to try to avoid that. And if you review our data, you will find that this patient did not lose weight, which is very important. We have always presented the low HG diet not as a losing weight diet, but as a healthy diet. A second argument is that when you do heat processing of food, you're also affecting vitamins and polyphenols. So therefore, a high HG diet that is produced by heating also contains lower vitamin and lower polyphenol, and perhaps the bad effect is related to those compounds. Also, heat processing not only produces HGE, but some other toxic compounds such as acrylamide, furfural, heterocyclic aromatic amine. Melanoidin, on the other hand, which is the final products of Maillard reaction, may actually be antioxidant with prebiotic properties. That means good. As a consequence, the Maillard products produced are present in high HG food, very likely are a heterogeneous mixture having both beneficial and detrimental effects within the same matrix. There have been many problems, general problems in the field of dietary HGE that I think have prevented the progress. There are too many HGEs, there are too many methods to measure, there is no universal agreement in terms of what is the most significant HGE and the best method to measure it. There are many confounders, as I mentioned before, during the interventional trial, such as caloric intake, destruction of vitamin, polyphenols, etc. And perhaps more important, the lack of collaborative, multidisciplinary team approaching the problem, eternal discussion among food scientists, biochemists, and clinicians. Future direction, we need to look at the effects of a prolonged low HG diet and the progression and complication of chronic kidney disease, specifically whether a low HG diet can decrease the rate of decline of renal function and or proteinuria. We need to look in more details at the effect of the low HG diet on the microbiome. We need to refine our understanding of the mechanism linking high dietary HGs to disease. Now, before I finish, let me remind that if we forget about the dietary HG diet, the low HG diet that I've been talking to you for the past 30 minutes, there are some other dietary interventions. The DASH diet and the Mediterranean diet, for example, have been shown to markedly prevent diabetes. Very important to them, prevent chronic kidney disease. Epidemiological associations have also shown an association between DASH diet, Mediterranean diet, and the plant-based diet in the progression of chronic kidney disease. So I'm trying to insist that dietary intervention is of paramount importance to prevent chronic kidney disease, and not only to prevent the appearance of chronic kidney disease, but also its progression to end-stage renal disease. However, this is frequently forgotten. In my renal clinic, the back of the patient bringing pills contains at least 20 different kind of pills. How many times a consultation is called to a dietitian? Very, very few times. I hope this creates some mindset which is important, and I'm ready. Let me acknowledge first many people who have played very important roles in helping me developing this concept in the past, and then I'm ready to answer any questions.
Great, thank you so much. A fascinating, very interesting topic. There's a couple questions in the chart. Dr. Mark Rakowski asking if there's any evidence of AGE play a role in those rare cases of non-diabetic nodular glomerulosclerosis. I think those are all heavy smokers.
Very much. I mean, the group at Columbia.
Really quick, can you just click on that little stop sharing button on the bottom of your screen, towards the bottom there?
I forgot to do that.
Below that screen in your desktop, above your
I blow this.
All the way down.
I'm very sorry.
There, yeah.
So I'm not sharing anymore. Okay? I'm sorry. Oh, definitely. The group at Columbia, I mean, the pathologists, they have presented a large series in the past, and they showed that most of that in those cases were related to smoking. And I didn't emphasize smoking because I was trying to emphasize more about dietary AGE, but tobacco does contain significant amount of AGEs that are produced during the curing of tobacco. So it's an important source. Air contamination also is an important source.
Right, exactly. There's another question Kiki posted. Do plant-based food like tofu accumulate AGE depending on cooking techniques at the same rate and/or the same level as the other food?
Plants-derived food, they generate less than animal-derived foods in general. That will be the general principle that I will use.
Okay. And Lane has a question. Is there any reference for AGE content in food database?
Is there any what?
Is there any reference for AGE content in food database?
Sure. Actually, I gave some in the course of but if anyone has any doubt, at the beginning of the presentation is my email address there, so they can ask me directly and I'll send them. I can send them at least 3 different dietary AGE databases available in the literature. Yes.
That's great. Wonderful. Lisa Juan and Karen Perez asked a very similar question.
I'm sorry, just one thing in relation to that, which is important, because the problem are the units in which the AGEs are expressed. So that has created some difficulties in generating a specific number. For example, when you say protein intake less than 60 grams per 24 hours, everybody understands that. But when I say so many 1,000 kilo units per that, and the other say so many milligrams, and the other one say so many millimoles, then people start to become a little bit confused. And that is the kind of agreement that we have not reached, and we need to reach. That's why in general terms right now, I've become a little bit more humble, in my opinion, and I will tend to advise to people in terms of high, medium, or low AGE rather than specific numbers. I'm sorry.
Great. Yeah. So 2 similar questions. One is asking what other cooking methods will lower AGE, since frying and boiling indication for elevated AGE. Same question is, what are the 2 best cooking methods to decrease AGE? Which is the worst cooking method?
I mean, remember, it is a chemical reaction that occurs spontaneously. And the main factors that you can study in vitro that lead to accelerate that is the temperature applied. The higher the temperature, the more AGE. The duration of application of the temperature, the longer, the higher, the worse. The amount of water in the system. The more water in the system, the less AGEs. So poaching is not bad. Steaming is not bad. Stewing is not bad. But you have a very dry, high heat, is problematic. pH is important in the sense that alkaline pH tends to favor the reaction. So if prior to cooking, for example, you marinate with factors that lead to a low pH, like vinegar, acetic acid, vinegar and a lemon and other factors, you may also prevent the formation of AGE. The cooking surfaces, metals, tend to stimulate the formation of AGE. So if you are preparing a great hamburger over metallic surfaces, that generate more than if you are doing over some ceramic surfaces, and so on and so forth. Those are the kind of modifications.
Great. Jackson One has a question. I actually have a similar question. Is raw food has the lowest AGE? Does that mean we should eating more raw-based food compared to being cooked? My similar question is the Japanese eating sushis all the time. Is that part of the reason their longevity is higher than other countries?
Well, do they live longer than in other countries? I thought that it was specifically in Okinawa, isn't it? Correct me if I'm wrong. I thought that the area of in Japan where people live longer is in Okinawa specifically, but maybe you're right. I'm not sure if Japanese live longer than
I
American?
think so.
Okay, so then it is that. Perfect. I'm going to use that information.
I think it's part of the reason, I guess.
I don't know. Of course, I don't know. I'm just kidding.
Hypothesis.
But then maybe part of the, part of the reason. I'm sorry, but you had some other question at the beginning that I ignored when we went into that.
I think that's it. There's one question is maybe we should throw away the Coke when you were talking about AGE, which I agree. I saw one of the slide, microwave food also have low AGE.
It's lower than the others, yeah.
Okay. All right.
So this requires, we have done this quite a bit. And again, I'm not a good cook. I can tell you this general thing, but I don't know how to cook. I mean, I know how to survive, but not a good cook. But if you are a good cook, you really, with imagination, you can create the most fantastic foods with a low AGE method. Oh yes, there was another question there that we cannot let it go, which is the raw food. No, I'm not advising to go raw. I mean, raw has a lot of implication, particularly when you're dealing with meats and other products. No, we are not saying that. Obviously, raw has the lowest levels of AGEs, clearly, but a low AGE diet doesn't mean that you have to go raw. Meats and other food have to be cooked. We are advising cook. We're just advising a different cooking technique, not the raw food.
Now, practically, clinically, are we at the point we are able to measure serum AGE level? Then we see high, we go back to the patient, ask them, how are you cooking? Are you smoking? Those type of, are we at that stage yet?
No, because still we are. There is a so-called Maillard meeting that happens every 4 years where people who deal with this kind of thing meet, about 400 people, food scientists, biochemists, physicians like myself, and everything is just fighting, and at the end, I'm right, I'm not right. And you know, I have no problem being the best. I mean, I'm always right. I mean, there is no doubt about that. So we are all always right, and the end result is that there is no agreement. So that's what I mentioned precisely as one of the problems. We keep arguing, and there are no clear-cut established guidelines. That's what we're missing, and that is a disadvantage in this field.
Great. Final question. I saw crock pot sounds like a good way of cooking then, but there's long duration but low heat. Yeah. I'm not sure. Is there a study on that?
No, it has not. That would be my general impression, but I don't have precise information, so I cannot confirm that. That will be my feeling.
All right. Great. Thank you so much. A wonderful, wonderful talk. I learned so much. Next time I would tell my patient, boil the food, steam the food, try to avoid fried food.
And sushi.
Exactly.
Okay.
All right.
Thank you very much.
Bye-bye. Thank you.
Bye-bye.
Bye-bye. So we back on, Jessica, what time?
Thanks, Wickles. We'll be back on in about 15 minutes or so.
Great. We'll be back on 3:30.